Hi everyone, lovely to see you. We've got a very special guest here. It's come from Kings. Very kindly come up this afternoon, not only to do a Bible, but also to do a presentation for us all. So my great privilege to introduce Gary Cook. I'm sure many of you know. He's a very eminent nuclear medicine physician working down in London and Kings, and he's been doing terrific work over many, many years on SPECT and PET, mostly in oncology. And he's in a wonderful position of having two total body systems now. And so he's going to be talking, I think, partly about that as well, and what they do in clinical molecular imaging in Kings and guys in London. So, Gary, thank you so much for joining us. We look forward to hearing what you've got to say.
Well, pleasure, and thank you for inviting me. So Gigi suggested I do a sort of a bit of a personal tour of what I've been up to. Now I've been back at Kings for, I guess, 14 years nearly. So I'll go through some of the projects I've been involved with, which is obviously just a small portion of some of the work that goes on. Not moving on for some reason. Okay. So yes, we're in a fortunate position currently, as I was just explaining to Ferdy actually, that the setup at Guy's and Tommy's and KCL, which is different from KCH, although they're also parts of King's Health Partners, is different from many places in that the PET Centre was set up as a university department many years ago by Mike Maisie and still separate from the trust, and the nuclear medicine department is run through the trust, and there's crosstalk, of course, between the two, and hopefully more in the future. But the PET Centre spread over both sites on the south of the Thames there. So the Tommy's site has always been the major sort of hub for PET, and we have another scanner over in the Guy's Cancer Centre there on the right, where we have an older 7-year-old Siemens short axis field of view scanner. On the Tommy's site, we have a PET-MR scanner, which is getting on a bit now, probably about 13 years old, something like that. And we're very fortunate to have acquired in the last 6 months 2 quadras, so long axis field of view scanners. The first funded by the MRC, and the second, somehow our head of school managed to persuade Kings to buy us a second one. So that's been brilliant, and I'll sort of touch on that towards the end of this talk. So I know many of you here, but for those of you who don't know me, I'm a nuclear medicine physician. I did radiology training in London as well at St Mary's, but my nuclear medicine time has been mainly at Guy's and Tommy's. I did my MD with Ms. Fogelman in the kinetics of fluoride PET and metabolic bone disease in the days of PET-only scanners before we even had PET-CT. And then I spent 11 years at the Royal Marsden setting up the first PET scanners, and then came back to KCL and Guy's and Tommy's as a clinical academic about 14 years ago. So these are the things I'm going to run through today, and you'll see the theme is largely on non-FDG, novel PET and SPECT tracers, or repurposing of other tracers, as well as some of the hardware that we've acquired. And I guess we can't give any imaging talk these days without mentioning AI and radiomics, which I have dabbled in a bit. So this is the sort of thing that interests me. There's people like Sally Barrington, who's just recently retired, a colleague of mine who's world famous for all the sort of phase 3 work she's done in lymphoma, or practice changing work with the FDG PET scans in lymphoma. But my interest is more at the front end of tracers and helping to develop them and assess them, either first in man or for new indications at least. So my first project when I went back to King's was around the area of bone metastases, and Ignis Fogelman, who unfortunately is no longer with us, was my mentor and one of my trainers when I was a junior at Guy's, and his main area of interest is metabolic bone disease, but he also interested me in the imaging of bone metastases, and this is an area of clinical need, as I'm sure you're aware. We're not very good at, well, we're pretty good now at detecting bone metastases, but we're not so good at determining when metastases are responding to treatment. We either get false positives with flares, or it just takes several months before we know if a patient's responding or not, whilst they're on their potentially ineffective and toxic treatment. So I'm sure you'll be aware of the sort of underlying biology of normal bone, how it's perturbed in cancer, but our normal bone is forever being eaten away by our osteoclasts, and new bone being replacing that with osteoblasts to keep our bone healthy and able to respond to stress. Now, cancer upsets this cycle either by increasing osteoclast activity, so the eating away of the bone outstrips the repair, and we end up with lytic disease, or in some cases, such as prostate cancer, for example, the osteoblastic part of the equation tends to take over, and we get abnormal osteoblastic bone instead. Now, for many years, molecular imaging has had ways of imaging bone metastases, so the good old bone scan, or the fluoride PET scan, which is really the same mechanism for detecting the abnormal osteoblastic activity. But this isn't ideal in that it's an indirect measure of what's going on. And I'm sure you're aware that in successful treatment, you get a flare whilst the osteoblasts sort of fill in the holes, and you can get increased uptake whilst the patient's actually responding, which is indistinguishable potentially from progressing patients. So although we've used these scans for many years, they're not ideal. And now we have the ability to look directly at the cancer cell, which is perhaps of more interest when we're assessing therapy response. But we mustn't forget the osteoclasts. They are the cause of much of the morbidity in bone metastases. And we do have ways of measuring osteoclast activity, and osteoclasts are a target for therapy. So denosumab, for example, bisphosphonates, and other targeted therapies for patients with bone metastases. So there is a rationale for trying to measure osteoclast activity, and I'll show you some work we've done with an alpha V beta 3 integrin imaging agent that is expressed on osteoclasts. So this was the first funded trial that I got going when I got back to King's. I was keen to look at the sort of the three leading contenders for the best ways of us being able to monitor response in bone metastases. And we had a cohort of bone predominant metastatic breast cancer patients being treated with endocrine therapy. And we scanned them at baseline and then again at 8 weeks. And for the fluoride scans, we actually did 12-week scans as well to determine whether we could pick up the flare or not. So slightly complicated here. So we used whole body MRI, diffusion weighted imaging, fluoride PET, and FDG PET to in all these patients. It was perhaps I was naive in trying to set up this trial in the early days, but you know how difficult it is to recruit patients, particularly if they're having to come back for 6 extra scans during the first 8 weeks of their treatment when they're not feeling too good. But they did, and we're grateful for that. So to run through these results, so the dotted lines are plus or minus 20%. The blue bars are the lesions that responded by a gold standard measured at 6 months, and the red ones are those that progressed. So just starting with MRI, the changes in ADC were sort of what you would expect, an increase in those that responded and a reduction in the progressors, but the changes were relatively small, and relatively few of them sort of managed to get past this 25% threshold. And I spoke to my colleagues at the Marsden, Christina and Moo and Nina, who are experts in this area, and they said, yes, you really need a 25% change to be sure it's a real change. In contrast, FDG was very good at determining those that were responding. This is early as 8 weeks, as I say, not so good at detecting the progressors. And one could argue that actually they're the more important ones for our oncology colleagues to know about. If they're responding, that's great, everyone's happy and carry on with the treatment. But if they're not responding, then you need to think about swapping treatment. And if you can't tell early on, then the patients, are liable to be getting treatment that's being ineffective for longer than they need. So, and then looking at fluoride, again, not quite as good as FDG at determining the responders. Looked quite good at picking up those that were progressing, but you'll notice there's as many blue lines here above the dotted line as there are red lines, and that's because, of course, you get the flare response with fluoride with the osteoblastic reaction. So we can't tell a flare from a progression, which is the problem with fluoride, unfortunately. So I think the conclusion of this is FDG is probably the best current technique we have, certainly for detecting early response. And you can see some scans here showing not much visible change with fluoride, although you can measure SUV changes, are much easier to see the visible changes on the FDG scans. And here's just this is another patient. So again, we could see or measure the changes on the fluoride scan in this responding patient, but it's much more obvious on the FDG scan. And that's just after 8 weeks of endocrine therapy. We get some very nice responses in these patients. Okay, so on the same theme of trying to improve our ability to monitor bone metastases, I was lucky enough to speak to the right person in GE at the time, in fact, Ian Wilson, who's now working for NPIP in the MRC, and they had this alpha V beta 3 integrin tracer, which they were using for angiogenesis imaging. And I just happen to know that osteoclasts are probably the cell in the body that expresses this integrin more than any other cell. So I thought it would be a good, my hypothesis was that this tracer could detect osteoclastic activity, and there was some preclinical work to support that from the States, but also that changes in osteoclast activity might be a good measure of response. So we started with prostate cancer, not because I wanted to, because as you know, it's not predominantly a lytic osteoclastic disease, it's just because that was the first grant we got. And I was pleasantly surprised that in these patients that the reduction in activity with this alpha V beta 3 integrin targeting agent, and this was a technetium labeled agent, so these are SPECT studies rather than PET, but we could detect the lesions. The uptake was higher in lytic metastases rather than sclerotic ones, so indirect evidence of the osteoclastic sort of angle. And we did see a reduction in activity in the responding metastases at 12 weeks compared to those patients who progressed on treatment. And the treatment they were having was standard docetaxel chemotherapy. Since then, Serac Healthcare have taken the tracer off GE's hands. They're kind enough to let me have some tracer for my interest in osteoclast activity, and we're running the FAB-B2 trial, just started recently with some funding from breast cancer now, but they're more interested in rheumatoid arthritis, and they've done a couple of trials with us at St. Guy's and Tommy's, and now doing some multi-center trials to try and get their product commercialized for rheumatoid arthritis detection and monitoring. Okay, moving to a different phase and a different angle now. I was, again, lucky in that we've got a large radiochemistry development or imaging chemistry and biology department within our school, which Phil Blower used to lead, Steve Archibald now leads. And Phil and his PhD student, Jennifer Young, developed this form of gallium PSMA with the THP linker. And the selling point at the time, we're going back about 8 years now, was it was an easy kit to make up, much easier than at the time the gallium PSMA 11, which everyone else was using. Because we'd invented, or not me, but Phil and Jen had sort of done the work, we had access to this tracer at a lower price, and it actually enabled us to start doing PSMA imaging 2017 before many people in the UK get access to PSMA or the funding. So that was great. And although this wasn't really a scientific study, it was one of the studies that we could perform then that you can't really do anymore, because we were able to ask patients were still getting bone scans and CT as part of their standard workup at staging or biochemical recurrence, which they don't anymore in our institution at least. But at that time they were. So we had some comparisons, and when the standard staging had been presented at the MDM, we would ask the treating oncologist to tell us what the treatment plan was. They then had their PSMA PET scan, and then we went back to them and said, now what's the treatment plan? And we found that biochemical recurrence patients, 34% of patients had their treatment changed, and in the high-risk prostate cancer patients, diagnosis about 24%. So significant changes. In fact, we didn't carry on using this tracer. It wasn't ideal, as it turns out, less sensitive than PSMA 11 and perhaps some of the new F18 PSMA tracers. In fact, we changed to PSMA 11, and I'll show you some work from that. So this is a recent retrospective analysis again. We've been doing high-risk prostate cancer patients virtually from day one, and the parameters we chose, luckily, just turned out to be the same that Michael Hoffman chose for his prospective study, showing that PSMA 11 imaging of these patients was indeed worthwhile. So a PSA more 20 or T3 on MRI or above, or Gleason 4+3 and above. So they were the criteria Michael used, and to say just we happened to pick on the same ones. And using those three criteria, 22% of our patients who would otherwise be eligible for curative treatment have have metastatic disease, mainly nodal, as you can see, but a few with more distant disease. So it makes a big difference, because in our institution they don't do nodal dissections. So if you haven't got localized disease, the surgeon's no longer interested in you, and you go off to see the oncologist for appropriate systemic disease plus or minus radiotherapy, maybe coming back later for surgery, but so it does make a big difference. If you've just got one of those risk factors, you can see the numbers here, that they're the chances of having metastatic disease, and as you'd expect, the higher the grade, Gleason grade, as measured by the ISAP grade, the more likely you are to have metastatic disease. And then if you look at patients that have one risk factor, about 12%, two risk factors, that doubles. And then if you've got the full house, almost doubles again. So very high risk. And then we got our friendly statistician to do a multivariable analysis. So all three risk factors were predictive of metastases. And the other one that came out positive was the number of positive biopsy sites, perhaps not too much of a surprise, but it's an independent predictor of metastatic disease. So I would say half our practice now is doing high-risk prostate cancer patients at staging. Okay, moving on again. So this is something that's probably the work that I've enjoyed most. This is a collaboration with a company called Nanomab, who set up in Hong Kong and Shanghai, and they did a phase 1 study in Shanghai with this technetium-labeled nanobody directed at PD-L1. And as you know, PD-1 and PD-L1 are targets for therapeutics, for immunotherapy for cancer, and made an enormous change in outcome of patients with lung cancer and melanoma, for example, who would otherwise have had a terrible prognosis. But we know that biopsying tumours, you only get one bit of the tumour, and it doesn't tell you what the other metastases are doing. And we know PD-L1 expression is heterogeneous, and we can't keep biopsying patients over time. So imaging would be a natural way of sort of overcoming some of the problems with biopsy monitoring or measurement of PD-L1 status. So it just so happened that the Shanghai group had done this phase 1 study. They didn't really have anyone that could interpret the images. And one of the people who used to work for Phil Blower was working for Nanimab in Shanghai at the time. And he just was back in the country and said, can I show you some images? And he showed me these horrible dog spinner images. And I said, no, send me the DICOM data. So he did. And I played around with it and we managed to get some nice images, such as the one you can see there, some SPECT-CT images. And it ended up being a nice collaboration where we did all the analysis of the scans and so on for them. And then Nanimab set up a branch in the UK so that they could take the work forward with us, which was a great opportunity. So our first study was the PCAN study, which I'll describe in a minute. The beauty of these single domain antibodies or nanobodies is that they're very small, so you can image quite soon after injection. The background goes quite quickly, the uptake in the tumours relatively quick. So we were imaging at 2 hours, whereas with the zirconium monoclonal antibodies, you're having to wait 1 day, 2 days, and so on to image patients. And the camel is because they're camelid derived antibodies, humanized antibodies. So this was we did 2 trials, the PCAN study, which is one we proposed, and the Pelican trial, which the company wanted to do as a phase 2 study to help the registration. So this is a bit of a combination of patients from both trials, but you can see the first thing here, the blue, each patient of the 15 patients here, the blue is the primary tumor and the green are the metastases. And you see there's a lot of heterogeneity, and in 2/3 of the patients, there was a difference of at least 50% between the primary and at least one of the metastases. So we know biopsying is not going to give us the answer about how much PD-L1 expression there is in patients who might be eligible for PD-1 treatment, pembrolizumab in these patients. We did we looked for correlation between our baseline pre-treatment PD-L1 expression on the scans compared to the immunohistochemistry, and there was a bit of a correlation, but not strong. But we didn't expect it to be strong because of the reasons I just said, that there's some heterogeneity. These graphs show, so these patients also had, as well as their baseline PD-L1 scan and a 9-week PD-L1 scan, we did baseline FDG and 9-week FDG, because we thought FDG is probably the best sort of reference standard for whether these patients are responding or not. So the y-axis is the reduction in SUV, so the lower down, the better the response, and the x-axis is the level of PD-L1 expression. On the left here, we have by immunohistochemistry, so not a good correlation with, or not a good prediction from immunohistochemistry as to the FDG response. But if we look at our PD-L1 status by imaging, there's a much tighter correlation or prediction of FDG response from our baseline pre-therapy scan. So we feel that this tracer is better at predicting response, at least early response, compared to the biopsies that the imaging is chosen on. This graph shows the difference between baseline levels of PD-L1 expression on the imaging in non-responders compared to the responders. You can see there's, as you'd expect, higher PD-L1 expression in the responders. And this is the change in PD-L1 expression on imaging over 9 weeks. Non-responders, if anything, it went up, and in the responders, the measurements went down. Here's a nice example. On the top row, you've got the baseline and 9-week FDG scans. On the bottom row, the corresponding technetium NMO1, this antibody was called. You can see that lots of disease, most of it has shown a complete metabolic response, but the primary and this left supraclavicular node are progressing metabolically. So most of the disease that responded showed high uptake of PD-L1 tracer, whereas the 2 lesions that progressed were actually showing quite low uptake. So we can almost predict a dissociated response in these patients. And the patient had another 18-week scan for clinical reasons because they weren't quite sure what it meant. And those two lesions continued to progress, and we had localized radiotherapy to those two lesions as a treatment choice by the oncologist to deal with that. Okay, moving on to another, not a new tracer. This FSPG has been used as a sort of competitor to FDG in some trials in Korea and in Stanford in the States. It's basically an amino acid analog, but Tim Whitney, who some of you may know, who's a preclinical chemist in our school, has been working on this tracer for years and is convinced it is a good marker for this system XC. So his thoughts are that one of the causes of resistance to chemotherapy and other therapy is that tumors are able to adapt to oxidative stress by this cycle here through system XC. So if this is overexpressed, the tumors are more likely to be resistant to therapy because they can deal with oxidative stress, and FSPG is a marker for this. So we've between Tim and I and our PhD student Amy Sharkey, who's a trainee radiologist, we've set up this trial looking at patients with lung cancer and non-small cell lung cancer and head and neck squamous cell carcinoma baseline and early imaging at about between 4 to 6 weeks to see if we can see changes. Well, one, if we can predict response by the amount of FSPG accumulation, and two, whether the change in FSPG we see correlates with the response that we see. We've only imaged 3 patients so far. I think this was the first one, and one of the first nice research studies we've done on total body or long axis field of view scanners. You see the nice dynamic images that we can acquire, for example, on this. So here we have the FDG of this head and neck tumor and the FSPG scans. These are the ones that you can compare quantitatively. So these are on the same SUV scale. So you can see the uptake in this tumor is actually relatively low for the FSPG. I wound up the scales to make the maximums the same on these two, just to show that there's some heterogeneity probably in FSPG expression across this tumor, which becomes a bit more obvious when you change the scale like that. So early days, we've had 3 patients who had 2 scans. We're doing some dynamic scans because of, I'll go back. Yeah, we're not quite sure whether we're expecting high FSPG accumulation, because FSPG goes in and out with XCT activity. So we're almost wondering whether actually the sort of K3, if you want, the extrusion of FSPG might be a predictor. But some early analysis of the data of n=3 so far by Lawrence Vass, who's doing some of the kinetic work for us, suggests that actually it's the PATLAB sort of method is the best model for predicting the accumulation in the head and neck tumors, at least, which are the only ones we've done so far. But you know, this is a nice story. So the preclinical work and the translation and the total body PET and so on, and our radiochemistry team were very, very pleased to have actually got a tracer past the line, because as Franklin and the rest of you probably know how difficult it is to actually, you know, get tracers to GMP and in man. And yesterday we got the first slides back, so we're looking at XCT expression on immunohistochemistry as well. So again, we haven't had a chance to analyze this, but it'll be nice to be able to correlate the imaging with the immunohistochemistry when we have enough data. So the next exciting thing that I'm looking forward to is, again, this is a collaboration with Nanomab, or they're probably going to change their name to something else, but it's the people that I know, and one of them is going to become my PhD student, and we're going to we've got hold of a Nectin-4 single domain antibody nanobody, Now, I'd never heard of Nectin-4 before, but having done a bit of rapid homework, this is a cell adhesion molecule, and like many of these molecules is overexpressed in a number of different cancers, and is associated with progression and metastatic potential, that sort of thing. But there's two reasons for being interested. One, it might work in cancers that FDG is not so good in, because it's known to be expressed in urothelial cancers, for example. Triple negative breast cancer FDG is pretty good. Gastric cancer is less good, and some non-small cell lung cancer. But also it's a therapeutic target. So there is already a licensed ADC for treatment of Nectin-4 positive disease. So it could be a companion diagnostic, or at least useful for looking at heterogeneity of uptake of T traces. And this is one of the first studies that's been published in triple negative breast cancer, so some very nice high uptake. So that's sort of in the pipeline. Looking forward to starting with that. So just to look at some of the other kit we've got. So we've not really, on the oncology side, used our PET-MR scanner, I must say, possibly to its full potential. We were all very excited when it arrived, of course, but I think, and collaborating with Vicky Go, who's great at the MR side of things, it's been good. But I think we struggled really to find an area where it really makes life easier or much better than PET-CT on its own. I did start this trial, the Prosper study. It was in the days when we were using choline rather than PSMA. And then COVID came along, so it's been through many changes, but we've eventually got about 25 patients who had PSMA PET-MR scans. They went off to have, most of them eventually had prostatectomies, so we've got histological correlation in them all. So we're just looking at one of my ex-MD students, who's now a clinical oncologist at Guy's and Tommy's, is now looking at the data and using the data to see if it would influence radiotherapy planning. So it wasn't the original intention of the study, but that's what it's sort of morphed into just because of circumstances. But some lovely images you can acquire on these scanners, as I'm sure you do on yours. So you've got your sort of anatomical detail, physiological, the ADC and the blood flow, and then the molecular information from the PET tracer. Okay, so you can't not mention AI and radiomics, and I've been here this afternoon doing a viva for a PhD student on radiomics, and it's something that I got quite interested in a few years ago, and I've sort of gone off it a little bit now. Partly because of the frustration of the robustness of and the reproducibility across machines and across sites. But as those of you who haven't come across it before, radiomics is basically extracting other metrics from imaging that we can't see by eye. So rather just size or SUV, there's various features that can describe heterogeneity of pixel values, for example. And we did quite a lot of work on this some years ago, but haven't looked at it too much since. And I think the other reason is why pick out your own features and analyze them one by one or in a model, when now we can just throw an AI machine at it and it will do it all for you. It won't tell you what it's finding and what features it's doing, but it's likely to be better at predicting what you want to predict from your image than sort of just landing on a feature by chance. And in fact, we did some early work with Giovanni Montana, who since moved to Warwick, who was, at the time, we'd never really heard of AI and convolutional neural networks, but we had a large data set of esophageal patients and all the follow-up clinical information, and he produced this CNN, and we trained it, and he was able to predict from the baseline esophageal FDG PET scans which patients would respond, and they all had surgery. So it had a Mandard score, which measures the degree of histopathological response, and you can see that the CNN on the bottom line there worked better than our standard metrics such as SUV or the TNM in predicting response. And actually, I think those figures are pretty good. They're not perfect, but if you told an oncologist this patient has an 80% chance of responding or not, I think that would be valuable information. They deal with, you know, measures of much less than that, and they're happy with that most of the time. So I think there is something in this, but I've not done much work individually in that space since then, but I just happened to sort of gain a PhD student a couple of years ago, almost by accident, but got this very gifted chap who's a musician and done some computer science and was really interested in natural language processing. So, and he was amazing at just getting things done. He's managed to get 60,000 of our PET reports from previously, and working on this AI algorithm, NLP method for extracting data from reports. And his first project was to look at lung cancer PET reports and to see if we could extract the TNM staging from the report sort of automatically. So something that can do it in a couple of hours rather than a person who would take, you know, several months to go through all these reports. And as you can see there, is on the left, we've got the internal data set that his algorithm was able to perform pretty well in getting the TNM status correct. The blue line is those where the report was uncertain about something, so it's less good at detecting uncertainty in a report. And then we're fortunate to collaborate with Thomas Wagner, who's at the Royal Free, who also has a Quadra, had the first one in the UK, in fact, and he had a set of reports that, so we've got an external data set. You can see it works quite well on an external data set as well. Not so good, again, on the uncertain reports. And his latest project is actually trying to extract actionable incidental findings from PET reports. You know, virtually every report will find something that is not related to the lung cancer, but the clinician needs to know about the aortic aneurysm, the bowel hotspot, you know, whatever. But and he's been working on this. He's just submitted it for publication, and might be able to see the figures there. But it performs pretty well. Relatively few false positives and false negatives when you just throw, you know, 2,000 reports at it. It took a long time to train them. That was me and one of my colleagues, Sugama, who's our clinical lead, sat down and sort of had to sift through a couple of thousand reports to sort of label them. But once it was trained, it seems to work quite well. Again, not quite so well on the external data, more false positives for some reason, although they report quite differently at the Royal Free. They tend to do a start at the top and work down, whereas we tend to do a more TNM type report. So whether that's something to do with it. But anyway, it's I never really knew what natural language processing is, and he teaches me each week, my student, so I'm becoming better at understanding. But he's done some good work with that, and it's been really interesting to work with him. Okay, so move on to long axis field of view or total body PET. I'm sure you know most of these things, but the advantage of being able to scan the whole body in one go is, of course, you don't have to do the step and shoot that we have to do on a short axis field of view scanner. But the additional advantage is, rather than just accepting the coincidence 511 keV gamma rays across one part of the body, we can now accept them from wherever in the body they originate from. So the sensitivity goes up, theoretically, up to about 40 times compared to a short axis field of view scanner. In fact, it's probably less than that in real life. It's probably about 10 times, but even so, that's an enormous change. And they're not 10 times more expensive. They're probably about 2 or 3 times more expensive. So, but anyway, so the advantages there are that you get much better image quality, less noise, and better signal to noise, faster scans. You know, we're using 7-minute scans now. People go lower than that. We just don't need to. Better temporal resolution, so you can start doing much better dynamic images. You can reduce the injected activity. We're injecting 2 megabecs per kilo of FDG. other centres do less than that. And there's a paper in the recent JNM where I think it was the Amsterdam group were looking at doses down to 0.3 megabecs per kilo and showing that actually statistically the data was pretty good. So, you know, we're getting down to very low radiation doses now from PET, and the CT has become more of the dose give up, and I'll come to that in a second. So, but potential disadvantages, of course, they're very costly, £7 million or thereabouts, and the servicing is expensive. Loads of data, so you need petabytes of storage to try and sort of overcome that. And I think that figure there of 25 gigabytes from dynamic scan is wrong. We're talking terabytes now, really, from dynamic 60-minute dynamic scan if you want to do that. And of course, the patients still take time to get on and off the scanner. So we're not trying to push it too much because we don't need to. Our waiting list has gone down to zero virtually, but we're doing 3 or 4 scans an hour now, whereas we would be doing 2 when we had the old scanners. As I mentioned, we still requires the CT part of the. So some of the things that we've got going to start with are a totem protocol, which I'll come to in the next slide, I think, which you may be interested in collaborating here. The FSPG study I described, one of our cardio-oncologists from the Brompton also is an academic in our school who did his PhD in cardiac imaging. So he's got a grant to look at multi-organ perfusion or rubidium uptake, at least, or kinetics of rubidium in patients with heart failure. And we're also developing, in collaboration with Siemens, a method for measuring the ejection fraction in any cancer patient who happens to sit under the scanner, because we can obviously look at their heart at the same time in the whole body scan. Some further work that's going to occur. In fact, it's not TROP2 anymore, it's the Nectin-4. We're very interested, as I'm sure you are, in doing some FAPI work in cancer and non-cancer related indications. Just as a bit of an advertisement, it's likely we will set up a copper-64 FAPI facility, not just for ourselves, but for others who may wish to use it. The advantage being the 12-hour half-life, it can travel around the country. And also copper's quite a short positron range, so the resolution of the scans is much better than gallium, which is the other sort of nearly available FAPI agent in the UK. Some more work that's planned. We've got a CAR-T therapy spin-out company at King's who are looking at therapies for solid tumours. They want to know whether the cells are actually penetrating the tumours. So we're going to use the Imaginab compound, the CD8 monoclonal antibody. They wipe out the T cells beforehand. So anything that's left is a CAR T cell. So we'll be able to monitor where they go, is the theory. And we're hoping to start that before too long. And we've also got a small grant from MRC to take the sodium fluoride kinetic work in bone disease a bit further, because we can now get much better measurements and maybe look at some more intricate kinetics. So the totem study, I sort of spent a year of my life going through the pains of R&D and ethics and all that sort of thing. But the purpose of this, we wanted to set up something where we're not wasting all this fantastic clinical data that's coming through the department on a daily basis. So we wanted to be able to use clinical data for research purposes and get patients permission to do that. We wanted to be able to do extra scans on patients to help us develop protocols or other research questions. So we wanted permission to acquire dynamic images, either pre-injection or whenever, and do some additional scans on patients who are coming for a clinical scan. And we were allowed to go up to 3 extra scans of 5 minutes each with a low dose CT of a millisievert. And we've applied for 10,000-1 patients. Within the ethics, we're allowed to use the data and share the data with researchers and industry. And we have a database sort of keeping tabs on all the all data that we're acquiring. So the main study is that we just ask every patient if they don't mind their clinical data being used in the future for research. And of course, most say, yeah, fine. But also we're running sub-studies where we're doing these extra scans and other interesting things to when patients are there in the department anyway. So as I say, it took about a year to get it through, but we have got it through. And I've already shared it with the Royal Free, Edinburgh and Glasgow, and in fact, Michael Hoffman in Melbourne. But if you want to see the paperwork, if you want to run something here, then it'll save you at least a month or two of pain. And I'm happy to do that. Just to show you the lovely quality of images that we can get from the dynamic. These are the 2-minute frames. We still do dynamic clinical scans on our prostate, our biochemical recurrent prostate cancer patients, so that we can see the prostate bed before the bladder starts filling up. It's actually quite useful. This is more just to show that you know, the images are lovely. The other thing, we're running a prospective study where we're acquiring 60-minute dynamics, to the hypothesis being that, as you know, we get all these false positive bone areas of uptake in ribs and so on. Is there a difference in the kinetics between the benign lesions and the real metastatic lesions? And I know Rod Hicks is doing something similar in Melbourne as well. But there's lots of possibilities. Now, as I say, we can get the radiation dose from the tracer right down with total body PET, and there's ways of getting the CT dose down, either by using a tin filter. The Groningen group think we can get down to less than 1 millisievert. You can even use the radiation from the LSO crystals in the scanner itself to produce a mu map. It's not good enough for, you know, to diagnose anything on, but you can get a free, virtually radiation-less attenuation correction from the scanner itself. So it does mean you can start looking at, I was going to say patients, people who don't, normal volunteers, other people who aren't necessarily patients, for some of the underlying biologically interesting things related to aging and, you know, things such as that. And with FDG, we can do lots of things. You've got a list there of some of the things we've thought of which might be of interest. Sodium fluoride, not just good for bones, but there's work on vascular calcification, atherosclerosis that we can do. And you can even do a GFR theoretically if you do a dynamic scan over the, you know, including the kidneys, then the sodium fluoride is filtered, so you could do a GFR. And then of course on the CT, you've got things like the coronary calcium score, bone density, body composition. So there's lots of data that can be extracted from other types of research studies. And we've got a big aging group at King's, and we've got, of course, our twins group, who are a great resource for looking at changes or differences in underlying abnormalities that are related to genetics or not. So things that we've got sort of in the pipeline, as I said, gallium nectin-4 is probably one of the next big projects. Maybe do a basket trial using some of the cancers that we don't routinely use with FDG, just to get a feel for heterogeneity and expression. Copper FAPI we're hoping to get hold of. We've got a CRUK drug trial going to application going in soon, and they've asked us to sort of tag on some FAPI imaging to that. But we've got interest in interstitial lung disease and cardiomyopathies. Now we're teamed up with the Brompton. We're also looking to start a study with the NF18 PARP inhibitor tracer in prostate, breast and ovarian cancer to see if baseline imaging can predict response to therapeutic PARP inhibitors. So lots of interesting things going on. Whether it will all come to be, I don't know, but it's keeping me busy at the moment. So I think that's all. Thanks very much for your attention. Happy to answer any questions or feedback by email or share totem protocols in the future.